So, turns out breast cancer-related lymphedema script. So here's a scenario. You've survived breast cancer. You've made it through surgery, through treatment, and you're ready to rebuild your life. But your body has other plans. The lymph fluid that should be draining from your arm gets stuck, your limb swells up, and suddenly you're dealing with pain, reduced mobility, and this whole new problem that nobody warned you about. Now imagine someone tells you there's a procedure that could help, surgery to connect your lymph vessels directly to your veins, the works. It's precise, it's targeted, it should work beautifully. So why would researchers then say, yeah, let's add something else to this? Why inject medication near nerve clusters after you've already gone under the knife? Seems redundant, right? Except when the results came back, they found something that nobody quite expected. So what was it? Breast cancer-related lymphedema affects somewhere between 1 in 4 and 1 in 5 women after breast cancer treatment. Let me paint the picture. When you have lymph nodes removed or radiation to treat cancer, the lymphatic system, that's your body's cleanup crew, gets disrupted. Fluid backs up, arms swell. It's chronic, it's often permanent, and it genuinely impacts quality of life. For decades, the main treatment was compression therapy and hoping. Then, over the last 10 to 15 years, surgeons developed this ingenious microsurgical technique called Lymphovenous anastomosis. Basically, they connect your lymph vessels directly to veins, bypassing the damaged area. It's elegant, it works for many people, but it doesn't work for everyone, and the success rates vary wildly depending on when you catch it, how severe it is, and a bunch of other factors we still don't fully understand. Enter the Stellate Ganglion block, a nerve block technique that's been used for years to reduce pain and improve blood flow. Someone asked the obvious question, what if you did both? This study comes from a team at Ewha Women's University in Seoul, South Korea, specifically from the Department of Anesthesiology and Pain Medicine, working alongside plastic surgeons at Samsung Medical Center. The lead researcher was Kang, Beak, published in the journal Lymphology in 2026. These are serious researchers looking at a real clinical problem that affects thousands of women every year. They published this as a pilot study, which is important context. It's smaller, more exploratory, the kind of work that asks, should we be looking at this more carefully? Here's what they did. 30 women with breast cancer-related lymphedema were randomly divided into 2 groups of 15. One group got the standard surgery, Lymphovenous anastomosis, nothing more. The other group got the same surgery, but then received 3 additional ultrasound-guided stellate ganglion blocks at specific intervals. 2 days after surgery, then again at 2 weeks, then at 4 weeks. Think of it like this. If the surgery is rewiring your drainage system, the nerve block is like temporarily turning up the volume on your body's natural healing response in that area. The researchers measured arm circumference at 4 specific points, 5 and 10 centimeters above and below the elbow, at baseline and then at 1 month, 3 months, and 6 months after surgery. They were looking for real, measurable reduction in swelling. So what did they find? Here's where it gets interesting. When they ran the statistics comparing the 2 groups head-to-head over the 6-month period, there was no significant difference between them. The group that got both treatments didn't come out ahead of the group that got surgery alone. That's the headline that would make you think, well, that was a waste of time and injections. But then you look at what happened within each group. Both groups improved. The swelling went down in both arms. That's the surgery working. But when the researchers looked more closely at the SGB group, the one that got the nerve blocks, they found significant reductions in circumferential differences at several measurement sites compared to baseline. In other words, the people getting the additional treatment showed measurable improvement, just not more improvement than the people getting surgery alone. It's like both paths led to the same destination, just maybe different routes. What does this actually mean in human terms? First, the good news. the surgery works. Lymphovenous anastomosis is legitimately helping women recover arm function and reduce swelling. But adding a nerve block on top of it, at least in this pilot study, doesn't give you a bonus. You're not getting better results by doing both. That might sound like a disappointment, but it's actually useful information. In medicine, sometimes finding out that two things aren't better together is exactly what you need to know. It saves you recovery time, it saves you money, and it simplifies treatment. The stellate ganglion block isn't harmful, but it also isn't the missing piece that would make surgery better. Now, there's an important caveat here. This was a small study. 30 people is the definition of a pilot. The researchers were explicitly cautious about drawing sweeping conclusions. It's possible that in a larger study, you'd see different results. It's possible that certain subgroups of patients, maybe those with severe lymphedema or those treated years after cancer, might benefit more. We don't know yet. What we know is this specific combination, in this specific group, didn't show an advantage. Looking at the bigger picture, this research sits at the intersection of two evolving treatments. Lymphovenous anastomosis is still relatively new in the grand scheme of cancer care. Surgeons are still learning when it works best, who benefits most, and how to optimize outcomes. Stellate ganglion blocks have a long history in pain medicine and vascular procedures, but their use in lymphedema specifically is newer territory. This pilot study is the kind of work that prevents us from assuming that more intervention equals better outcomes. It's foundational. It says, okay, before we train 1,000 surgeons to do this combination, let's make sure it actually works. The next logical questions are huge. Does timing matter? Would different dosing schedules of the nerve block show different results? Are there specific patient characteristics that predict who would benefit? Would this combination help in other types of lymphedema, not just cancer-related? There's a whole research roadmap here. And honestly, the fact that the surgery alone is working well is kind of the real story. This is a technique that's legitimately improving lives, and we're still in the early stages of understanding its full potential. So here's the actual takeaway. Sometimes in medicine, doing less is doing more. A surgical procedure that reconnects your lymphatic system is powerful enough on its own. Adding an extra procedure doesn't enhance the results, and that's actually incredibly valuable to know. The researchers didn't prove that nerve blocks help. They proved that you don't need them as an automatic add-on. That's not a negative result. That's medicine getting smarter, more efficient, and more focused on what actually helps patients. The real question now is what comes next. Whether this combination might help in other contexts, whether there are subgroups we haven't identified yet, and whether other complementary approaches might be the actual missing piece. Turns out, scientists have been busy, and they're not done yet.